Awesome. So our next session is a Wellbeing and Women in Medicine panel. It's currently being live streamed to other medical students across New Zealand, which is awesome. So yeah, you'll be able to ask any questions at the end of this panel, and for those who are live streaming, you can either text it to the number on the whiteboard or comment on YouTube below the video. The panel's going to be chaired by Elizabeth Berryman here, who's the NZMA board member and past NZMSA president. We also have our panellists here. Starting from the very end, we have Dr. Alistair Papali'i-Curtin, who is an ophthalmology trainee and has also had several leadership positions, and his wife, Dr. Jess Papali'i-Curtin, who is a surgical registrar. We have Dr. Miriam Martin, who is director of Kiwis and AUSSTAT. We have Dr. Ruth Spearing, who is the NZMA board member as well as being a consultant haematologist. And last but not least, we have Dr. Jane Ruck, who's a padiatrician. She's worked in several countries and she's also an art historian. So yeah, we have a great mix of speakers and I'm really looking forward to this. Take it away.
Thank you, everybody, and thank you for being here today. It's really wonderful to see so many students at the Clinical Leadership Forum. So as Dizella's kindly done, she's introduced all the panel members for us. Here's a bit of a profile about each of our panellists. They are all very distinguished people, and we are so privileged to have them with us today. And yeah, I'm flicking through these a bit quick, sorry. And I'll flick that one even quicker. This is a bit of agenda for today's panel. So we're going to start off with introductions, which we've just had, and then I'm going to talk a bit about why we're even talking about women in medicine, and a bit about the history, about the first graduate. Then we're going to talk about hierarchy in medicine, and this is Dr. Jane Ruck. She's going to come and do a presentation. Some of her masters was on hierarchy, so it'll be really interesting to hear. Then we have Alistair and Jess are going to talk about wellbeing in medicine, and they're going to share a bit of their own story with that. Then we're going to ask for the rest of the panel's story about their journey through medicine, and then we're going to open up for questions. And yes, as Gisela said, we've got my cell phone number is up here, and this is the one time where you're allowed to take your phone out, and just feel free to send me a text anytime, and so it's really good because then I can ask the questions, or we will take questions from the floor as well. And then we'll finish up with a bit of a summary and final remarks. Does that sound like a plan? Great. Right, so why are we even talking about this? So these photos here, this is of Emily Seidenberg. Now, she was the first graduate from the Otago Medical School in New Zealand. She went through quite a lot to get to medical school, and we have an absolute honour to follow in her footsteps. However, she had quite a bit of difficulty. An influential group of senior staff from the medical school, led by Sir Truby King, who is the founder of Plunkett, were not only anti-woman in medicine, but actually campaigned against higher education for women in general. They argued that it placed too great a strain on them at such a momentous period of their lives when it was detrimental to the vitality of the race. They should be at home raising children. In 1909, the Otago Dean gave a lecture along these lines to an audience which included churchmen, members of parliament and doctors. Fast forward now 108 years, and now on average 60% of the medical intake are women. How things have changed. Although it would appear that women are now seen equal to their male counterparts, the term lady doctor and other subtleties which many of the first women doctors endured lives on. In a recent Medscape article, research in America showed that there were more men than women in major department-based leadership roles in all 9 specialties that they studied. Overall, women accounted for 13.9% of departmental chairs, 22% of vice chairs, 21% of division directors, and 39% of residency program directors. The highest proportion of women were actually in O&G. Another recent American study showed that although 47% of medical students in their study were women, that only 26% of grand round speakers were women. On another side, the AUSSTAT, which Ian Powell spoke to us earlier today, they did a study in 2015 of SMO burnout. It showed that women were more affected than men. Also, in Beyond Blue's survey, which is a mental health survey in 2011 in Australia, showed that female doctors had higher rates of depression and anxiety. Personally, I have worked with many well-meaning supervisors who asked, what specialty would I like to do? I've learnt to say, I'd like to do ONG, but I'd also actually like a family too. So I'll probably go into general practice with a special interest in women's health. Every time I say this, they reply, oh yes, that's a good idea. It's tricky managing training and family. Until my last run was at North Shore General Surgery. And I said my usual line, and the surgeon said, no, I don't think you should settle for what's easy. If you want to do something, oh no, not that duty's easy, sorry. But if you really want to do something and are passionate, then go for it. He says, I tell my daughters all the time, don't let anything hold you back because you're a woman, because you want a family, or because of your age. So now this is why we're talking about wellbeing in medicine. We have a fantastic panel of doctors, and they each have their own personal story of their journey in medicine. And we have an opportunity to share their stories with you today. I find them inspiring, and I hope you do too. We also have a couple, Dr. Jess and Dr. Alistair, and they are going to show us how couples can support each other to achieve their goals. So boys, this is a matter for you as well. Emily Seidenberg said that although Truby King was one of the most staunch anti-woman doctor campaigners at the time, when it came for her getting her first job, he was one of the most helpful people of all. He ended up getting her and her classmates their first job at CLF Psychiatric Hospital in Dunedin, when all other hospitals in New Zealand said no. So it does show that even if you have some ideas about things, you can change and help as well. So now I'm going to hand this mic over, and I'm going to work down. Yeah. Thank you.
Well, good afternoon. I'm Jane, and thank you very much, Gisela and Liz, for those introductions, and also a big thank you to Chris for giving me the opportunity to share some perspectives around wellbeing and diversity in leadership, but especially in the context of hierarchies in medical organisations, their necessity and function, and depending on the way hierarchies are structured and put into action, their shortcomings and abuses. I'll offer some suggestions based on both research and personal experience towards achieving more cooperative and collaborative approaches to operating within medical environments and organisations that benefit everybody involved, but including medical women, obviously, since that's the topic of this session. But really, I think that all of us are affected by these issues. It's a very interesting experience for me to reflect on being a medical person again, having jumped ship from working as a part-time paediatric consultant into academic art history about 6 years ago. So after long experience in the enforced conformities of practicing medicine, which are essential to ensure patient safety and standards of care, it was rather terrifying to realise that art historians actively encouraged me to take considerable risks as a way to gain insights. But nothing I researched and wrote about was likely to put human lives at risk. So obviously, enforced approaches and standards of care in varying settings in medicine are there for a very good reason. I'm very grateful to have experienced seeing the human world and its complexities from a much bigger perspective through studying history and art history, and particularly because of exposure to a wide range of different cultures. My way of thinking about medicine and power discrepancy and what equality means has changed enormously. Recognition of the way organisations are structured in hierarchies to display dominance of particular groups and to reinforce power relationships. Cultural assumptions around relative rank and powerlessness, particularly involving gender, age, religion, race, place of origin, colour and sexuality. How people display their status and power in the way they dress, what and who they control, and how this results in widely discrepant degrees of dignity, respect, reward for time and effort, and freedom of choice. My husband, who is a radiologist in academic, public hospital and private practice settings, and may well have taught some of you, and my 3 young adult children. My daughter has just finished law, and I also have 2 sons, one who's a musician and one who's still at school and thinking about doing medicine, have been engaged in some pretty intense discussions around the dinner table at times based on what I've been reading. Hierarchies are a feature of all organisations and are necessary to enable efficient decision-making. Ideally, decision-making within organisations, both big and small, is directed by contributors who hold the greatest knowledge and insights for a particular context. If everyone acts as if they're equal, you could go round and round and round forever trying to come to some kind of consensus because everyone wants an equal say. So that can be very time inefficient and time consuming. So it really does make sense for there to be some kind of hierarchical structure. Research by the University of California at Berkeley in 2010 involved extensive review of varying hierarchical structures and their effect on outcomes. Steep hierarchies, which centre on giving a loud voice to just a few and silencing most others, associated with what's known as rankism, tends to promote individualistic self-advancement at the expense of others. In contrast, much flatter organisational structures encourage team participation, cooperation and collaboration, and making the most of diverse and complementary skills. Not surprisingly, flatter organisational structures are associated with higher morale and well-being, greater productivity and rewards, and the responsibility for outcomes is shared more broadly. If the leader operates from a highly individualistic position, as is typical in steep hierarchies, it creates somebodies and nobodies, insiders and outsiders, which is, of course, hallmarks of rankism. And, of course, this is completely counterproductive to ensuring cooperative and collaborative approaches from other team players, which would ensure that varied aptitudes, knowledge and skills are made the most of. So it's vital that all those involved have the capacity to have a voice to ensure that vital information and perspectives are shared. And that's really regardless of your stage of training because, as is often commented on, medical students actually have a lot more time to talk to patients, to get a lot more social history and to get patients to talk. Some of that information is highly valuable and no one else has had a chance to get that. I guess the trick is tailoring how much of that information you share and when and what context. And certainly on ward rounds, sometimes sharing a lot of information is probably quite time-wasting if it's not completely relevant. But sometimes the funny details that you pick up are actually very important. A recent report by the Royal Australasian College of Surgeons looked into the steep hierarchy in New Zealand surgical teams. A report came out in 2016, the end of last year. And particularly was looked at by a surgeon called Ian Sybil, who'd previously been very much involved as an army doctor. And what was found was that patient safety was being quite significantly compromised by the steepness of hierarchies, and in particular, information sharing, because surgeons at the top of the hierarchy were inclined to think that everybody knew what they knew and they didn't really need to tell anybody about anything. And people further down the hierarchy were quite untrusting of sharing information that could be very vital to patient safety. So there's been quite a shift within the Australian College of Surgeons to try and promote more level hierarchies, and it particularly moves towards briefing and debriefing as a formal strategy, because it's really recognised that steep hierarchies are very counterproductive to good communication, and surprisingly enough, it's patient safety that ends up being the motivator to get things changed. It's important to recognise that many hierarchies in medicine have existed for centuries and are traditionally steep. A few experienced individuals are put in positions of power and oversight of a group with less status or experience in a stepwise fashion. Ideally, this leadership focuses on ensuring safety and for teaching and supervising approaches to patient care. As is apparent from this meeting, there are many women doing great things in leadership positions in medicine in New Zealand, and the proportion of women in leadership positions worldwide is slowly, very slowly increasing. However, worldwide leadership positions in medicine are still largely held by men, as Liz has mentioned, And research suggests that typically men tend to focus on outcomes in a kind of top-down manner. This is obviously the generalisation, rather than overall team functioning. Research also suggests that in general women are more likely to adopt more cooperative leadership styles, centering on maximising the contribution of the skills of diverse members of the team. There is a shift happening, but many women in leadership positions in medicine perpetuate the steep hierarchical styles that they've experienced during their training. So often being recognised as a leader means adopting the prevailing culture. And the associated risk of power going to your head is certainly not gender specific. In preparing for this talk, I informally surveyed most of the medical women I know, and all have well-established careers varying from academia to public hospital specialists to private practices in Australia and around New Zealand. All said spontaneously that the most trouble they'd had from undermining behaviour and bullying that they'd encountered came from other women, and typically while they were senior medical officers, not students. My experience would certainly reinforce that. By far the most sabotaging behaviour I've encountered throughout my medical career was from other women. That's really kind of disappointing, I think. It is, of course, human nature and quite instinctive to favour those who seem most compatible to your own way of thinking, or seem to have attributes most like your own insiders, including favouring those least likely to cause disruption to your own sense of importance. So rankism plays in that aspect, but also rankism comes in downplaying any competition, creating outsiders. And my most frequent encounter has been sabotage, really, or deliberately undermining any impression of competence, whether it's timing of scheduling or the amount of work that you've been given, or giving you work that's really impossible to do in a time frame. There's quite a lot of subtle stuff that can go on. So existing power structures tend to be perpetuated. New leaders are selected on the basis of familiar characteristics that are long associated with powerful positions. And after many centuries of power dominance across the globe, it's not surprising that in medicine, as with other professions, white men with higher social and economic status still dominate leadership roles and hold positions associated with greatest monetary reward. Hierarchies in medicine are all about power and who holds it and who benefits from it. If leadership approaches ensure that others are treated and considered with respect and dignity, everyone benefits. In contrast, abuses of power result in demeaning and shaming practices and very concerning lack of accountability. And it's really this lack of accountability that is a significant problem in steep hierarchies, because if you're really at the top of the tree, who's going to hold you accountable? Many aspects of medical culture and organisational structures involve very long-standing power imbalances, and this continues to impact on women, particularly in significant ways. Inequalities of respect and recognition on the basis of entrenched power discrepancies are features of rankism. But hierarchies within medical organisations as we know them, given my interest in history, are long rooted in history. It was fascinating for me to discover that about 600 years ago in the Middle Ages, when academic medicine, kind of as we know it, first originated, along with theology and law. They were the three kind of postgraduate elite areas of study. From the outset, they came out of church law, not common, or they came out of churches, out of monasteries. And so those students in medicine, law and theology were under church law, not common law. And so they were known for being lawless. They were known for taking all sorts of liberties with the fact that common law really couldn't keep them in line at all. So from the very outset, the academic medicine that we know has had this sort of lack of accountability built in. It's kind of part of the sort of arrogance of medicine that's long existed for about 600 years, really. So, but also, of course, women weren't part of medicine at that time, and for a very long time, academic study was really confined to men. During the Enlightenment of the late 1700s, there was a real decline in the power of the church and the monarchy, with a rise in scientific thinking and rationalism. And it was during that time that virtually everything in existence was classified into systems of importance and merit. So everything was put in kind of hierarchies of what counted and what didn't. And of course, women were well down the hierarchy. They weren't particularly important. And the main emphasis for women was on financial allegiances and on childbearing. But of course, women had a very high mortality rate in childbirth. Until the late 1800s, women in Europe could not even inherit their own money, even if they were left money, it was completely controlled by male members of their family. And that really didn't change until the very end of the 1800s. If women managed to be academically educated, it was usually due to the support of a male patron, usually a family member or a benefactor. The 1800s was also the time when academics divided up the human body into different areas of importance. You know, the heart, of course, is way at the top of the tree because it's really important, and skin and obstetrics are kind of way down there somewhere. They're not so vital. And if you go to anatomy museums, even the Auckland Anatomy Museum, you'll see that the museum is still organised in that kind of hierarchical fashion with the heart in the middle and the urology and obstetrics things way out in the periphery. It's really quite interesting. Those hierarchies still exist. It's been a very recent change, really, the past 40 to 50 years. That was a huge, it's impossible really to overemphasise the impact that effective birth control had on enabling women to enter professions, and also the rise of feminism with demands for equality. And beyond feminism, there was very active challenging of existing power structures, especially those centred on white male privilege, from really gained momentum from the 1970s. So, research around hierarchical leadership styles and outcomes in the past decade has repeatedly highlighted that steep hierarchies with powerful individuals at the top, who assert dominating lines of control over others, really only benefits the most simple, repetitive tasks, pretty much like a factory where you have a supervisor and everybody's doing kind of menial jobs. But for any complex situations, steep hierarchies compromise good outcomes. They fail to make use of diverse talents and insights, they impede flow of information, and they compromise patient safety, as well as staff morale and well-being. So individuals further down the rank hesitate to speak up, and important information is not shared, and valuable contributions are not made. I'm not sure how I'm doing for time. Just to briefly share my contrasting experiences really around this. I became a registrar at the University of Utah in the States. I entered the program because somebody else pulled out, and I was very fortunate to be appointed chief resident, but I'd only been there about a year, and I still don't know quite how that happened, but I'm hugely grateful to have been given the opportunity. But it was very striking that the head of the registrar program, who was a woman and well known throughout the States, had a very strong collaborative, cooperative style of leadership. Her name is Lucy Osborne, and she was very kind of well known in general academic paediatrics within the United States. She was very strong on openly recognising the fact that a lot of clinicians had children and how that intertwined with their career. She herself was a solo parent of a son who she was incredibly proud of and had not let that dent her career at all. She really ensured there was a lot of mentorship and collaboration, and especially in training and research. We'd have research meetings where everybody shared their research and was very, very encouraging and supportive. There was generally very high staff stability and morale. I was surrounded by a lot of really strong women. There was a very close collaboration with allied staff, technicians and nursing staff, especially nurse practitioners, a lot of sharing of information, a huge culture of respect, and often a lot of fun. So the overall impression, if I can come up with a sort of vague picture, is that there were many highly talented, happy fish kind of swimming around in a big, inclusive, clear pond. We were all kind of swimming away happily and interacting with each other. There were, however, some quite tough parental leave constraints, and when I had my daughter, I found it quite difficult that I was expected to go back to full-time work quite quickly, but there were abundant childcare options even for very young children. We came back to New Zealand when my daughter was about 18 months old. My visa ran out, basically, and my husband still isn't that happy that we came back, but that's a long story. Coming back to New Zealand in the mid-1990s was a huge shock to me. I found myself really amongst a small number of big, unhappy fish competing to dominate the top of a small pond, while others were actively pushed aside to the murky, drying up periphery. The extensive health system restructuring at this time introduced a whole lot of management control, which was largely perceived by medical staff as interference, and it became very hierarchical, very competitive, and a very toxic environment in general. There was a lot of insider-outsider positioning, and it was made very explicit. It's only recently I've really considered the huge stresses that almost everybody was under in the public system at that time, and I guess most of the experiences I had, which were really pretty toxic, really reflected the stress that everybody was under in terms of imposed competition for resources and job insecurity and increasing paperwork and administrative requirements. I ended up doing a whole lot of locums, and I quickly realised that the locums I was doing were for some extremely stressed colleagues who basically had a lot of stress-related, really nasty illnesses. And I guess in the end I was sort of doing my caring bit for kind of holding the fort for them while they got better. It wasn't the ideal way of doing paediatrics, but I certainly learnt a lot and encountered some pretty challenging cultures in the process, I guess. So even though it was paediatrics, which is essentially a lot of caring and dedicated people involved in caring aspects of medicine, and paediatrics is known for kind of being a caring profession, a lot of people were really struggling to operate in an environment that was anything but caring. Some of the negative experiences I had was, for example, I applied for a job and one of the senior consultants encountered me coming out of a lift and took me to the side and said, "We've seen your job application, but just to know that we're not actually going to look at it because you've got small children and there's somebody who's applied for a job who doesn't. So just don't think you're going to be considered." I was taken out for lunch by a senior consultant and who grilled me about the research project I'd done in the States, which was I was at the point of publishing, and she told me in no uncertain terms to back off because one of her registrars was about to publish in the same field. So, but this was all kind of covert stuff, and it was very hard to, because you'd come away from it going, did they really do that or say that? And it was only your word against theirs. It was all done very behind the scenes. So, my suggestions. You're all going to encounter varying degrees of rankism in medical teams and with very different hierarchical structures, and I think it's really important just to kind of have a bit of objectivity and recognise what's going on in terms of rankist practices. So be aware of it and what it is. Try and offer to support to anyone who's being subjected to it in toxic ways, and if you can, gently confront those who are perpetuating it by drawing attention to it. Just draw attention to the fact that they're being rankist, that they're playing power games really with the way they're approaching things. Everybody's under great time pressure, and seniors are human beings who are subject to sleep deprivation and stress, and I think it's worth considering that they are human beings and are not perfect. I think it's useful to use first names for everybody as a first up levelling thing. There may be senior consultants who don't necessarily find that normal, but I really think it's important. And I'm actually talking to most of the senior consultants, they actually quite like being called by their first names. It makes them feel like real old fogies to be called by titles. They don't like being called prof that much. Be aware, just from feedback, that there's it is necessary to accept critique, but that shouldn't be shaming. Try and show respect and cooperation towards everyone, and that includes nurses and especially the ward clerk. If you're really nice to the ward clerk, they can go an awfully long way for you. If you give them work, they will put your work to the top of the pile and they won't ignore it and shift it to the bottom. So be friendly to the ward clerk, ask them about their life, know their name. I think it's a real tension for us in medicine between being individualistic and competitive. I guess we've always all got that side to us. We wouldn't be doing medicine. But that's really quite counterproductive to being cooperative. My son, who's now a professional musician playing in various bands, I thought had a really good approach to this. This is my final kind of thing, really. How many of you have all been in musical groups or sports teams or committees? Okay, so you probably understand that, as he was saying, you have to choose your moments to be individualistic. You know, you have to choose your moment for your little solo. The most part, you just have to kind of be part of the team and act for the greater cooperative good.
Wow, you've had a lot into that. Thank you so much, Jane. That's really amazing. So I'll hand over to Alistair and Jess. Thank you. The floor is yours. This bit.
Thank you. Kia ora koutou. I'm Jessica and this is Alistair. Hi. We're married. And our kind of brief for the panel was talking maybe a little bit less about women in medicine, a little bit more about well-being in medicine, which is a massive topic, and obviously everyone here has probably a lot of insight into that topic. So we just thought we might talk a little bit about our kind of journey through what is known as the decade of darkness. It's what is referred to once you finish medical school, that next decade of your life of training. And just maybe just how we've kind of managed it or are managing it, because we're in the middle of that. And just a wee disclaimer that I guess the way we've chosen to do things, or our approach to things, is one way of doing it. It is not the best way, it is not the only way, and everyone's relationship is different, and everyone's journey is quite different. But should I go first?
Yeah.
Okay. Thanks. So I am from Wellington. My mum is Cook Island, my dad's Pākehā, and I'm the oldest of 4 girls. And when I finished high school, I worked as a legal secretary, and that was, I was just saying before, that was a job that I guess made me realise the real value of being educated in higher education and doing a job that was slightly more varied. I did a Bachelor of Arts in Psychology and Māori Studies, mainly in Te Reo Māori, and then I guess through that gave me the confidence that I could actually succeed at tertiary education, and I went on to do medicine from there. We met when I was...
Second year.
I was second year, Alistair was 5th year, and...
It was good because we met on the ferry going to Freshers Camp. NZMSA has a place close to my heart because I was the NZMSA rep in Auckland, and I was going to Freshers Camp to tell them about NZMSA, and then I looked across that ferry and I was like, who's that? So I felt better when I found out that we were the same age. Then I was like, okay, this is justifiable. You know?
Yeah, true. But I was upset because we left the end of that camp and I thought, oh yeah, he was such a great guy, like we really got on. And he never even asked for my number or anything. So it took a while. But then...
That was just because I thought she was so amazing that I was like, man, I'm just happy being friends, you know? Like, I think that's as far as I'm going to get here, so, yeah.
So after that, then we got married when I was 5th year, or going into 5th year?
Yes.
No, 4th year. So we got married at the beginning of my 4th year, and the med school wouldn't give me any leave. I was on general practice, and the nice general practitioner gave me some leave for my wedding. And then I guess our journey kind of together. Alistair was working at Middlemore. He was a house surgeon there. And Middlemore is one of the busiest hospitals in Australasia. So I remember being that time he was working and I was at home, often alone. I remember this one time I was doing his ironing, which I never do now, ever. And I was ironing his shirt and I was crying because I was so lonely because his hours were so bad. He was just working so much. Not that's not a point to write down or anything, but I wanted to do a rural year, and so Alistair moved with me to Whangarei, and at that time he was quite interested in a surgical career, and he thought that would be quite a bad move for his career to move to Whangarei, but he came anyway, and we ended up having a really good year, and it ended up being really good for his career anyway. And then I did my trainee intern year at Wellington. I transferred down because Alistair... It was better. I'm from Wellington, and it was better for us to work in a bigger centre for him to do ophthalmology training. And it wasn't. I had gone into medical school really set on general practice. I guess it was a bit about what Liz was saying as well, that I really knew I wanted to have a family. I knew I wanted to have kids, and I was really interested in community work and working with families in the community. But I think a part of it, I had made this 5-year plan that I would do my house surgeon years, have one baby, go back part-time to general practice, then have another baby, and then finish my general practice training. But my experience of general practice, I hadn't actually enjoyed it at all. And on the flip side, I really loved surgery. And I hadn't really let myself even entertain the idea that I could do surgery or that I should do surgery, because I had this 5-year plan you know, and it was all kind of like laid out in my mind. Not even that you can even be sure you can have kids when you want to have kids anyway, but I'd planned it. And I remember distinctly this one night, we had gone out for dinner, and I was just saying to Alistair, oh, I'm really not sure. By the way, I made this plan. I don't think you even had made that plan. I was saying, I'm not really sure about this plan that I'm thinking and going into general practice. At this stage, I was PGY1, and I was doing my general surgical rotation as a house surgeon, and I really loved it. And Alistair was so supportive. He was just like, give it a go. If you're interested in surgery, just give it a go. And I was quite, like, I've always, he's a really supportive person, so I've always, like, expected that. But I actually felt quite bad, because looking at the way I had responded to the situation when he had wanted to do surgery as a career, and he had been thinking about general surgery, my main response towards his career decision was out of fear. I was really worried. I was like, oh, but how's that going to, you'll never be home, and we'll be moving cities all the time, and how is that going to work out? And so when he'd often talked about wanting to do a career in general surgery, I had been perhaps not as supportive as what I should be. And looking back now, that was all based out of my own fear of how that would affect me and this life that I had planned with this happy family. And so when he was really supportive of me saying, give it a go, just let those kind of plans go to the side and just see what happens, I was really grateful for that. And I guess that kind of gave me the courage. From then I started going down this surgical line, which means a lot of research, a lot of hours, and quite a challenging kind of 10-year period ahead, as with all specialties, but I guess the hour demands, and it's slightly less flexible than some of the others. So then Alistair got posted to, he got on his training scheme for ophthalmology, and he got sent to Dunedin. And I, at that stage, was very keen on plastic surgery, and I was like, oh, this is disaster, because Dunedin is like not got a thriving plastic surgery centre. I went anyway, because I think it's fun. Yeah, it's fun. I mean, a lot of people don't, but we really didn't want to do long distance. And actually, it ended up being a really good experience. The plastic surgery unit down there, sure, it's small, and it's not a training centre, but it was an amazing experience. I was the only plastic surgery registrar, so I got all the operations, all the patients, all the on-call, and so that was really, really good experience, and we really enjoyed living in Dunedin. And then now I'm working at Heart Hospital in their plastics unit, so I'm still a non-training registrar. I'm still waiting and applying each year to get onto training, but that's currently where I'm at, is working there, and we're not sure where we're going to next, because it's always a surprise. The college will let you know maybe a few months before you have to move where you're moving, or it will depend on whether I get onto training or not as to where we go next. But I just thought a couple of points that I think, reflecting about where I'm at in my journey and reflecting maybe about relationships, one of the things I think is really important, and that we've kind of found, is that reciprocal sacrifice is something quite beautiful within a relationship. And within a relationship that's really safe and where you value each other, it's something that I guess Alistair has quite taught me, that he was really willing to sacrifice his dreams or his career for me to have my career, but I was initially less so for his. But what I guess I've kind of learned is that, sure, I've moved to Dunedin, and perhaps people would say that that wasn't a great career move, and I've moved there for his career, but equally he would do exactly the same for me. So for now, I'm kind of at that crucial stage of trying to get on training, and it's more important as to where I am now, and Alistair would happily put his training on hold for me to be able to do mine, which is it's quite a, yeah, it's a beautiful thing. I think the other really important thing, and this doesn't just apply to romantic relationships, but no matter how good your career is, you can be at the height of your career, you can be doing so well in your career, it will never make up for having a really bad life outside medicine or being really unhappy outside medicine. And I think we're far better doctors when we're happy, when our relationships outside medicine are thriving and doing well. We're better for our patients. And so I just think it's never worth sacrificing the relationships to achieve your career goals. I think the career goals will work out, but the relationships won't just work out without, really working hard on them. And that's, towards family as well. And I guess one of the other ways that we've really tried to make it work or prioritise things is taking lots of time together when we can, because it's obviously quite a busy life, and doing holidays and things like that when we can, which is, I think that really makes a difference, relaxing and stuff.
Yeah.
Shall I let you talk now?
Okay. So I think when I was at your stage, I didn't realise what I was getting into. I think getting into medical school and the idea of medicine is super appealing. It's competitive, it's prestigious. You see Grey's Anatomy and you're like, man, that's going to be us. And it is us. I mean. But what I didn't realise, I remember I was sitting in something like this and I was thinking, I'm not going to work long days or weekends or night shifts. I'll just choose a contract that doesn't have all that and I'll be fine. I just didn't realise that didn't exist. But that's the thing is, you kind of think, I'll be alright. This applies to other stuff. Wellbeing applies to other people. I'm going to get on fine. But then you realise, man, when you're in work, you leave 1 o'clock in the morning, you're back at 6 o'clock in the morning. You're like, wow, what am I doing? But that's just what you have to do to get through. And I think now's the time to learn how to enjoy your life. You kind of think, once I'm a graduate doctor, then I'm going to have this great life and it'll be fine. But what you don't realise is, we're 30 now and we're still studying. We haven't finished yet, And I remember choosing medicine thinking, I'm going to be so old, I'm going to be 23 when I'm finished, But at least I won't have to do any more study and that's going to be it. No, you guys have to just keep going. And the great thing about being a doctor is you get to work full time and then do med school after hours, basically. And then do all your study for your Part 1 exams, your mid exams, your Part 2 exams. It's basically all med school all over again. I didn't realise that, so hopefully that's just enlightening for you guys.
Really encouraging.
Yeah, so that's tip number 1. But the thing is that it's wellbeing, it's so important that you actually enjoy it now and learn how to deal with your stress now. Because as you sort of realise, med school's the easiest part of your medical journey, I think. But at the time, you're super stressed out, right? That's not belittling the stress that you guys have now, because it's really the journey of learning. That learning curve is tiring. You're always in new environments, you're always picking up new information, and it's draining. Can the clinical guys remember the first day in hospital? You come home and you're like, oh my goodness, I'm so tired, And then it's like that when you're a doctor. You're just like, oh man, what's happening? You're like, each stage is super draining. And then to think, now I've got to go read my 10 textbooks and memorise those. You're like, oh man, what's going on? But I think it's once you adjust to each new stage, then you have a greater capacity to then, deal with other things. So for me, after my first year in Middlemore and just barely surviving, my second year was in Whangarei. And when we moved for Jess's career, I was thinking, man, how am I going to get onto training from Whangarei, But then that was actually my in, because once you're a doctor and you're relieving, for example, you have access to all the different teams in the hospital, and if you can get through your jobs that you're now more accustomed to because you've done all of that in first year, you then have a bit of spare time where you can then jump into extra surgical lists or jump into the minor, operations, and then figure out for yourself, is this what I want for my life? Do I enjoy this? I did an informal survey of my colleagues as well, and was like, would you guys choose medicine again? Oh, maybe I shouldn't tell you the answer. First of all, I was like, what would you say about surgical specialty? And they were like, don't jump into it too soon. Because you don't know if you're going to really enjoy it. Sometimes the attraction is, this is really competitive. I want to get in there and, achieve and be one of the select few that get chosen. But you don't know what you're getting into, So
You have to really want it.
yeah, it's trying to get as much first-hand experience as you can to then see if you really enjoy the job. So once I was in general surgery, I tried orthopedics first, and then I was like, man, this is cool, but I'm not macho enough to be these guys. So I was like, all right, okay, not orthopedics. Then I was like, okay, what about general surgery? And I was like, man, this is really exciting. But then I was like, this was just the experience I had with where I was particularly placed. Then I thought, oh man, maybe these guys don't really get to see their families as much, and their kids kind of hate them, and that's tough. And for myself, my parents got divorced, and I sort of thought, man, I don't want to have a family where people, don't get to see their own parents or their own family. So for me, personally, I steered away from that. That's not everybody's experience by any means. That was just my experience. So then I found ophthalmology, and I was like, man, these guys are pretty cool. And so that's just what I
All
thought.
by nerdy ass standards.
Yeah. But, then I found that it was a great mix of medicine, great mix of surgery. You can take it to the third world. It's amazing. Why would you do anything else? But, for me, that's when I found, okay, this is something I enjoy, but they only take 4 to 5 people a year in the country. And I was like, oh, man, how am I supposed to get onto this training scheme? So that's the second point is, if it's competitive, don't get put off. Find out what you need to do and do it, right? So for Jess, last year in plastics, they took 3 people in the country for the whole year. And you're just like, well, that could be off-putting, but if you actually enjoy it, you don't want to be doing something else. You see a lot of doctors that are burnt out or not enjoying it, but at the same time, you see the guys that are enjoying it. And what are they like? They're super passionate about it. I've got a consultant who just loves the retina, and he's just like... He's like frothing about the retina, and you're like, yes, and you want to be that kind of doctor where you just can't wait to go and see another retina, But you don't want to be those doctors that are just hating their life and just focusing on the negative aspects, because you guys will find that it's easier to then focus on the next person or the next job that you have to do, and then lose the beauty in your interaction with the patient right in front of you. So I had a patient who was, he had schizophrenia, he was blind in both eyes, and he was too afraid of having cataract surgery, and we managed to, talk him through it, and we had a really good discussion and found out, these are the risks, you don't have to do it, but, this is what's going to happen if you don't have it. The next day, he had perfect vision after cataract surgery, and when he was in my office, he was crying because it was the first time he had seen his grandchildren in 17 years. That's how long he had not been able to see for. And it's that stuff you're like, that's why I did medicine, But it's not always the massive... Oh, the time, sorry. It's not always these massive things about where you save a person's life and stuff. You have to see the beauty in each consultation, because if you don't, then you just start minimizing your job. You kind of think, when I'm a doctor, I'm going to come home each day immensely satisfied of what I've done for humanity.
But you don't.
Yeah, you don't, because it just becomes normal, and then you're like, I've got 80 people on my list. I need to discharge half of them. Let's just get them out the door, That kind of thing, where you can start to reduce your patients to just mere numbers. But for each person, it's so significant that they're in hospital, that they've got this condition, that if we don't see the beauty in our jobs and really savour it, we then run the risk of just losing the privilege of medicine, So for us, we prioritise each other, and we know that if our relationship isn't working, then nothing's really worth working for us. But we see each other as a team. If Jess succeeds, I succeed because we're part of the same team, And if Jess is having a bad day, similarly, it's the same for me. I think 2 points for guys. I don't think just because we have we're guys that our career is more important than females. So Jess has more degrees than I do. But I initially used to think, maybe women should stay home with the children and I'll go to work, right? But then so there's hope for you guys or girls if your partners think that way. Because we talked about it and then we're like, well, hang on, why does that make sense? Jess has more qualifications than I do and has worked just as hard to get to where she was. So I similarly should be willing to sacrifice my career to allow Jess to go forward. I used to make this joke, like when people are like, what are you going to do when you become a consultant? I was like, I'm going to be the most qualified stay-at-home dad there is, you know. But then, you know, after a couple of times I was like, wait a second. If Jess said that, no one would laugh. People would be like, well, that's just expected. You're the woman. You have to have children, you know. But for guys, somehow you got a laugh from people when you told that story. But actually I was like, well, no, that shouldn't be the case. Our careers are equal, and it's whatever works for the team, you know. So, and it has worked out in every case for us. But I think it would be.
We've got no kids.
Yeah, but. But so far, that's a choice that we've made as well. Hopefully, we can have kids. But
you have to finish now.
Oh, okay, I have to finish. What was my other thing? I was going to say something that I thought was important. No, it is important. I forgot. I can't remember. But yeah, for us, we just thought that we'd want to share our story, and hopefully, you can take something useful away, and you know, stay well on your journey of medicine. Thanks, guys.
Wow, we could listen to these guys all day. Thank you so much. So we have two more very important people on our panel, but we've got 5 minutes left of our session. So we've got afternoon tea straight after this. Is everybody happy just to keep going? Yeah? Okay, if you need to duck off to the toilet, feel free just to leave and come back. But next up, we'll have Miriam Martin.
What do you want me to talk about?
Just a bit about your story.
Okay. I saw Liz put a note up on the Women in Medicine page, has anyone had a baby during med school, to talk at this forum. So I guess that's where I'll start. And the reason I agreed to come and speak was because I thought if I could save one person from having a baby during med school, then I've done my job. I've got two older sisters who are doctors. I come from a medical family. My father was a GP and delivered 300 babies a year in the 60s and 70s, so we never saw him, and he was always out at 11 o'clock at night seeing patients or whatever you do in those days when there were no cell phones. So I never really wanted to be a doctor, but I ended up doing it anyway because it's a long story. Ask Ruth, she'll tell you. But when I got to fourth year, my younger sister Sandy and my older sister Janine, who was a GP, said to me, have a baby during fourth year, it's a really easy year. So stupid me got pregnant and had a baby in August of fourth year and had quite bad preeclampsia and ended up in hospital and had this tiny wee baby who is called Doogie Howser. I don't know if you know the program Doogie Howser was around. It's a 12-year-old boy who was a doctor, and the program followed him around. But he came to med school for the rest of the fourth year and some of fifth year. And it was a really hard time in my life. And then in fifth year, I thought that when they're a year old, they're really cute. And you think, oh, this is so easy. Let's have another baby. So I had another baby. And he was born at the end of was it TI year? In my elective, I was 34 weeks pregnant, walking around in Fiji. Delivering babies, and it was so hot that I just basically got the consultant to sign off my elective and went home and sat in the air conditioning for the most of my elective. And I had him as an induced labour as well because of lots of complications. But anyway, one thing I can say is a lot of my friends and colleagues have all had premature babies or difficult pregnancies, I think because they work too late in their pregnancies, so they work until they're, I don't think you should work past 32 weeks, and having babies while you're trying to do med school is just crazy stuff. So then I became a house surgeon. It's really hard being a house surgeon when you're breastfeeding and you've got toddlers. I have an amazing husband. He's very supportive. He's a youth worker. And if you're still on the hunt for a partner, I'd very much strongly suggest teachers and nurses as good groups of people to work your way through. My husband's been amazing. He's been a house dad at times in my career, and he works from home. So after 4 years of being traumatised in the health system, I did an ONG run, I did a PEDS run, trying to get out of the hospital system. And it was in the 90s. It was a terrible time in the 90s. I remember the RDA were talking about limiting hours to 65 hours a week, and I had this realisation. I was thinking, oh my God, I think I could probably do a specialty. And I remember there was an article in one of the women's magazines that was talking about professional women, and they were like lawyers, and there was one doctor, I think it was Sally Lane, who's a doctor up in Nelson, and I was looking at these profiles of these women, and I was thinking, I would dream of a part-time 40-hour-a-week job. It's just 60, 65 hours a week when you've got little children is actually really difficult. So I think the point I want to make is that it's really important to really carefully think about your timing, and talk a lot to your partner. There's a lot of juggling that goes on looking after children when you're working, and and the childcare. I was very lucky. I had a friend who was a padiatrician, and we shared a nanny for a year, I think 2 years, and that worked really well for her, and it worked well for me. But there was a lot of organising that went into that. We had to buy houses within a block of each other to make it work, and we had to interview nanny together, and we had to constant juggle, and this is in the days before cell phones, constant juggling. Almost every day was juggling, and my husband, who's a saint, would do all the extra childcare that came around because of all that. Like Catherine would just not be home, or no one would come and pick their son up, so he'd end up having dinner and being bathed at our house, and then we were thinking, it's now 8 o'clock, should we put him to bed or should we wait for them to come home? So there's a lot of juggling. So when I got to the end of 4th year, I thought, I can't do this anymore. And my registrar said to me, I've just been locuming around Australia, you should do that, it's really fun. So I had a bit of a chat to him, and then figured out that I could actually work in Australia as a locum and fly backwards and forwards and earn in a week what I earn here in a month. So I started doing that. I was flying over for a week a month for about a year in the 90s, and my husband works from home, so it actually worked really well for us. And at the end of that year, I thought, I've been quite entrepreneurial all my life, and I thought, and I had all these people ringing me up asking me, how did you get this work in Australia? And so eventually I ended up setting up my own locum agency, and I basically within a few years had this massive business with 45 staff. So 45 staff, not 45 doctors, but 45 recruitment consultants and administrators, and hired a manager. And by about 2008 it was all getting too much to juggle, so I stopped, and I was actually needing a little more business experience to try and understand how to run a business. So I started doing an MBA, which I really, really enjoyed. I enjoyed all the papers, and because I basically could do it part-time, I sort of ended up stopping doing any medicine. And then we had an earthquake in 2011. I had a couple of commercial buildings that got a bit munted, so then I spent 2 years doing insurance work and legal work, and finished my MBA, and then suddenly realised I hadn't worked for 6 years as a doctor. But it was actually, if anyone you talk to says, I wish I'd never done medicine, or you hear that kind of message, medicine is actually really interesting. It's very flexible. It's a great career. And I was trying to find another job, thinking I really need to do something a bit more interesting than doing insurance claims and working with lawyers and bankers and doing boring stuff like that and writing marketing. And so I thought, well, I actually used to have an interesting job, so I started doing medicine again. And last year I did first part ones of urgent care, and I really like urgent care. It's like the interesting bits of every specialty and none of the boring bits. So, and if it gets a little bit too hard, you just hand them over to a specialist, and you get to do orthopaedics and pull joints and bones and get to do little plastics things, which is quite fun. So I really like urgent care, and so that's where I think I found my niche. It's taken 20 years, but I've finally got there. So yeah, thanks for inviting me. So don't have babies in 4th year.
Well, I will. I know that you guys need to have some nice afternoon tea, so I'll keep mine really brief. So I have now been qualified, would you believe, 40 years this June, and wow, I still love medicine. You know, it's fantastic having a job that you still jump out of bed and really, really want to come to work. And I guess I was lucky. I kind of fell into haematology. I was 5 months pregnant. We'd resigned from Christchurch. My husband had a job down in Dunedin. And then I was asked, would you stay on and be a registrar, because a Rhodes Scholar from over at Oxford has written up his MPhil. Would you mind staying on for another 3 months? So I did that, and suddenly realised that this was a specialty where you just got to know your patients so well. You really interacted with them, and yet it was also the cutting edge of science and really great clinical skills required as well. So all of a sudden, there I was. You know, I had planned seriously not to go back to work till the kids were at school. And here I was now. I was 8 months pregnant, and I presented myself to the professor of haematology down in Dunedin and went, you probably don't know who I am, but I'd like to train in haematology. And it just shows what a fantastic person mentors can be. So John Pettit, whose son I now mentor up here in Christchurch, he went, yeah, I think we can get you on a part-time training scheme. And Women in Medicine, there'd been a group called Women in Medicine who had specifically gone to the government and organised for part-time funding for these small number of women who were actually thinking of having children at that stage of their careers. And so I got my Part 1 physicians, and then followed my husband over to the UK, and my money transferred over with me to the UK. So I continued my training over there, did the Australasian exams by myself, sitting in a room all by myself, and then returned here as a consultant. And I guess if there are a few key messages, one of my other mentors, Dame Ristio, Norma Ristio, she said to me very early on, one really important thing, and this applies to the guys as well, do the things you love in life, get somebody else, pay somebody else to do the other things. Yeah. It's so important. The other thing is, yes, just have the most wonderful holidays with your spouse and your kids, and actually enjoy your kids. So, you know, obviously I didn't give up medicine until my kids went to school, but I did manage to train part-time, and I still feel very sad that when I came back, the concept of a woman in the department was bad enough. A part-time woman would have been a step too far. I would have loved to have gone on working part-time. And just, it's interesting because my kids say that they can remember, because I was only working part-time when they were young, I really, when I was at home, I was able to be much more concentrating on them rather than sitting having coffees with the other mums. I would be down on the ground, etc. So do be aware that if you do want to drop your hours and become part-time, just make sure that you've worked it out well, though, with other members of the department, because we have seen some conflict. I'm chair of the senior medical staff, and we have seen some conflict where women have dropped their hours without really making sure that they're not just putting the burden on other people. So just be aware of that. And then very finally, in terms of, in fact, probably two things. First of all, in terms of, yes, I agree with Jane. In fact, it has been, throughout my career, I haven't had too many enemies, but actually probably the people who have made my life difficult have actually been other women. And often it is because medicine has so many, if you think of the disc personality, it's the gentle, passive people who make up 70% with the C's and the S's, who actually don't like people who are too direct, etc. So often our nursing colleagues actually find a forthright female doctor quite difficult, so just be aware of that. Put a lot of time and effort to getting to know your charge nurse as well. The ward clerks are the easy ones. They're always lovely. But
Nurses will really pull a lot for you. Yeah. Don't pretend you know stuff you don't know, though. They know far more than you do.
Absolutely, absolutely, yes. And then I have been very, very privileged in the last few years to have some fabulous leadership roles, both in chair of senior medical staff, but more recently as a board member of the New Zealand Medical Association. And seeing young leaders coming through that organisation has been just one of the most fantastic things. And I would like to ask all of you this evening to make sure that you go away and vote for Liz as the next chair. She will make a fantastic chair. She has got really great skills in terms of governance. She's a director of her husband's private business, so she has got the depth of knowledge. And the fact that Harvey White, who is professor of cardiology, world-renowned person, is absolutely happy to be her deputy chair indicates how much we think of Liz. So thank you.
Thank you, Ruth. That's very kind. And also, Ruth is standing again for the member of the board, and she also needs you to vote for her. And she's been a wonderful treasurer, and to be honest, it's been quite tough. And Ruth's been a real mentor during this time, and I just really want to publicly say thank you to Ruth for all your support and the other members of the board as well. So I think 5 minutes, so we'll just do one wrap-up question. I've got so many questions that have been texted in, and I think there's a lot online as well. So it would be cool, since we're using technology, if we could take this online, and I could ask if some of the panel members would be happy to answer on Facebook some of your questions. I know you've got a private group for NZMSA as well, so we could take the questions online. Sorry that we've run out of time. So last question for a wrap-up is, what do the panel think changes will be needed in society or in medicine structure to allow women to flourish in the future?
I think for me, Alistair is really, hearing what Alistair's saying is hugely encouraging to me in terms of mutual sacrifice, because for the generation of male doctors that I'm amongst, I think that was a very unusual thing for them to consider, and would have taken a huge amount of negotiation. And although I've had numerous discussions with my medical husband about him pulling back from what he's doing at times, the practicality of that has been extremely difficult. And also, a bit what you've both said in terms of children and pregnancy, the best plans in the world don't dictate what kind of pregnancy or children you have. I mean, I also had complications, and with my second child, my waters broke just about at work, and I was back on the postnatal ward that I'd been working on the day before as a patient. So the nurses literally shut me in, and if I stepped out the door, I was actually bumping into the patients I'd looked after the day before. So, I mean, it was kind of weird that it was at National Women's. So, your life and your work can really overlap in weird ways. I was just glad I got home. But nothing really prepared me for my third child, who, as a pediatrician, you think you know a bit about children and development, and he was the biggest Klingon in the entire universe, and basically would not be left with anybody except me. And was a child who at preschool would be shaking the gate and howling his head off because I'd walked away. And it takes... I couldn't do it most of the time. I didn't have that kind of fortitude to make him so miserable. So, in fact, I wouldn't sacrifice having him for anything, but he put a huge dent in my career. So he's thinking of doing medicine himself, so maybe he's making up for it. But you can't predict your children, I'm afraid, and sometimes they count more.
And if you go to the New Zealand Medical Association website, you guys had put some questions up last week, and you'll see that I didn't answer them. The reason I didn't answer was because I became a grandmother in the middle of the week. So I agree very much with what you say. I think we need to push for more reasonable hours at RMO level, but also SMO level, because it's actually when you're SMOs that you actually start getting really burnt out, and you don't know what the demands of your family are going to be. I've had 4 potentially fatal illnesses in 3 family members in the last few years, and you've just got to actually have working hours that are reasonable, and we all need to be pushing for that. And I think it's fantastic the RMOs have gained better working conditions this year. So yes, I think we all, both for the guys and for the girls, we need better working conditions, and we'll fight for those.
Yeah, I agree that for women to flourish in medicine, it's going to need better hours and more flexibility from everywhere, and guys especially when you've got female colleagues. It's never going to be easy to have to be a woman in medicine, because you're going to have a period in time when you're going to have to choose where you're going to put your age you are when you have your family, and it's going to be 2 or 3 years of really difficult juggling. And I reflect back on the 6 years that I had where I didn't work as a doctor, and then trying to get back into medicine. Don't take big breaks, because it's really hard to get back in. So that would be my message. And also the other message I'd have to people, which I forgot to mention before, is just remember that a pregnancy is actually 38 weeks from ovulation, not 40 weeks as you learn in your obstetrics, because I know a few people have actually miscalculated that around exams, which can be quite lethal.
Disaster.
Yeah, bit of a disaster.
Thanks. I think the same changes are needed in society as are needed for more Māori and Pacific doctors, more Indigenous doctors in other countries, and that's just things of inclusiveness and mutual respect and changing the way we talk about things. Like even what Alistair was saying, the kind of dialogue we have around women in medicine or men in medicine, like you never would walk up to your male consultant and say, "Oh, what are you planning to do about your children? How is your career life fitting in with your children and your family?" Yet people feel that that is their right to always ask women. And I think it's the same with, like some of the way we talk about or race or ethnicity. Oh, what are you? You must be something. You must have something in you. And that kind of discussion is on the pretext that white is it, that's the majority, that's the basis we're all working from, yet you look different to my perception of white, so you must have something else in you, and it's my right to ask you that question and for you to tell me the answer I want to hear. And if someone asked me that question and I said, "Oh, I'm from Wellington, I'm a New Zealander," they'd be like, no, but what are you? Where are you from? That kind of stuff. And it's the way that we talk about all these issues. I think that's a good place to start for many of the issues that we kind of face in medicine.
I think it's our perceptions as well. Like, I know you hear about people on maternity leave, and when their colleagues talk about them, they see it as a burden because then they have to pick up extra on-call or pick up extra workload. And so it's exactly that. It's those perceptions then colour the way that you would approach it yourself. I think so. I think it starts with us actually thinking about these issues and thinking, maybe the way that I've approached this subject up until now might not be the only way to approach it, and being open to these different ways of doing it. But also, once we get to a structural level, we actually need to resource the system so they can take into account people, stepping in and out of the workforce. Like, if we have specialty areas where there's only 3 or 4 places, there simply aren't any substitutes for those positions when you take that leave, So it's then thinking about resourcing these specific places and making sure we've got enough relievers, to take annual leave. And I know people think, I don't want to be a reliever because it's going to be bad for my career. But my take on that is it gives you access to every team in the hospital. Use that to your advantage, So being a reliever isn't isn't that bad, and it can help people on their journey, and you'd like that the same done to you if you're in the same position. So I think it starts with us, but there's also other things that we need to consider as well.
So I'd like you all to join me in a massive round of applause. And I think it's now morning tea, unless Gisela and Jenny, you've got anything?
Yes. Actually, I'll just, yeah. So, yeah, thank you to our panel. It was really, really good. Learned a lot, yeah. I guess we'll see how we go with our, the rest of our careers. But yeah, also a massive thank you to Chris O'Toole, our Wellbeing officer. He's the one who organised this panel. So yeah, a huge thank you to him.